We have a lot going on in the Harvard Department of Ophthalmology, and I think, as you know, my focus and those of many of us are in macular degeneration, and have been really thrilled to be part of the advances in the neovascular or wet form of macular degeneration. And those are being recognized this year with the Champalimaud Award for the work in bringing VEGF, or vascular endothelial growth factor inhibitors, to patients. And now we're able to see that 1 million people worldwide receive those injections for macular degeneration, but also for diabetic macular edema and retinal vein occlusion. But clearly there's lots more to be done, and we are pursuing several different areas, as are others around the country and really around the world. So I think in trying to understand where to treat or where to go after earlier forms of macular degeneration, we really need to understand the pathophysiology better. And in looking at the information that's come out earlier on, obviously, from epidemiology and clinical observation, now added to particularly with genetics and molecular biology, you can end up putting the pathways into several categories. And I really have narrowed that down to 6 pathways. The first is age, and I think age is kind of a hard nut to crack. I don't claim that we at Harvard are able to do that one yet. But then the others, big one is lipid and lipid metabolism and transport, and I really think that's an exciting opportunity, and we can come back to that. Inflammation, and by this really sort of smoldering chronic inflammatory processes, that including things like the complement pathway, is another important avenue. Then cell adhesion and the extracellular matrix is another target that people are looking at, probably a little bit less at the moment. Angiogenesis, we've sort of talked about and covered. And then things related to cellular stress and toxicity and really cell death. And so this gets us into things like neuroprotection, which we are pretty keen on in the Harvard Department and think there's a lot of opportunity there.
So tell us about some of the work that will be presented by your cohort here at Harvard.
Sure.
Preview the forthcoming attractions, so to speak.
Well, thanks. There's quite a lot, and I won't even attempt to cover much of that, but I think we touched on lipids and lipid transport, and there's some exciting work being led by one of our investigators, Dr. Dimitrios Vavas, at Harvard, looking at ways to basically suck out or really remove the lipids that accumulate in the outer retina to see if you can give something systemically that will really help with that. And that's really based on work by Christine Curcio and others who've demonstrated this accumulations of lipids in the lipid wall, and then deposits and ultimately drusen in dry macular degeneration. And we think that's targetable. She talks about getting rid of the oil spill, and we really think that's got promise.
To what extent does existing armamentarium of hypocholesterolemic agents have an impact? Have the studies shown that this does have an impact in terms of decreasing the incidence, decreasing the severity of dry macular degeneration?
Well, the statins are an interesting story, and I'm going to cover a little bit of this in the Weisenfeld lecture on Monday. And people were obviously interested in those early on to see whether statin use could decrease either the incidence of macular degeneration or its progression. And overall, the studies were really mixed. In fact, there was a big Cochrane analysis that showed that really there seemed to be no benefit. Robin Geimer has had a more recent study looking to see if statin, and in particular statin, could have an effect, and seemed to get a little suggestion of something there. And what Dr. Vavas has done is to look at the cardiovascular literature, and there high-dose statins can actually prevent restenosis of vessels and even lead to resolution of the plaque. So he's approaching that using high-dose statins in patients, select patients with macular degeneration that really have quite a bit in the way of deposits accumulating, and has some preliminary data that looks really exciting.
One of the issues has always been bioavailability. Do you get enough statins to the right place? And the blood-brain barrier is a very complex barrier. Do we actually know that we're getting statins at an effective level at the sites at which they need to act?
Well, sure, that's a good question, and I think Vavas has probably addressed that empirically. Here, we're not trying to get really across the blood-brain barrier so much as, it's really at the level of the choriocapillaris capillaris Brooks membrane, sub-RPE, and at least the evidence to date suggests that you're able to address that.
Because one of the challenges now with statins, as you're probably aware, is an increased incidence of diabetes, the memory effects, and of course the problem with high-dose statins, and that is chronic myalgia, muscle pain. So it's sort of a mixed blessing in terms of the side effects.
Yeah, although it's interesting, the myalgias, the muscle problems that are really probably the most problematic are not dose-dependent. They're idiosyncratic. So if you're either going to get them or not. If you get them, obviously that's not a good thing. And really, the issues in following patients with the high-dose statins is more following their liver function tests and actually thyroid function. But so far, and again, it's very preliminary data, but it looks pretty safe. Certainly, many people are on statins currently. It's kind of amazing how much that has penetrated. But this is only one approach. I don't think it's going to be the be-all and end-all, but it's an interesting observation and has some promise with drugs that are off patent and out there and available.
So switching gears to the inflammasome, obviously this is an area of hot interest right now. There was some discussion presented at the Harvard AMD conference in October with regard to antiretrovirals and their value as positively influencing impact. How far has that work progressed?
I think that's still going on. I think the inflammasome is an interesting target, and there's sort of two camps on that. It's either good or it's bad, and hopefully we'll be able to figure that out over ensuing months and years. But the inflammasome, interestingly, looks like it, may be responding to these depositions of lipids primarily. The nucleic acids and things is another approach, but certainly the complicated and altered lipoproteins may be a target for the inflammasome and maybe why it becomes involved, similar to what it does in gout with crystals. It's sort of responding to these complex molecules and leading to inflammation. That was Dean Elliott who was presenting the early stem cell work, and I think that was exciting, at least from a safety standpoint. And it really looks, with that stem cell approach, that we're trying to get trophic factors to the retina, so it's not about rebuilding or regenerating a whole retina. But I think that's going along nicely. I haven't heard information about when the phase 2 is coming, but maybe we'll get to hear that over the next few days.
Excellent. Professor, I want to thank you ever so much for granting this interview and sharing with us your unique perspectives.
Great. Thanks very much.
Thank you. Do you want to add anything else?
Yeah. I mean, unless you want a little bit on neuroprotection, we kind of missed that one, although it's going to be Vavas again. But I'm not trying to just give a plug, it's just the things that I know.
Sure, absolutely.
Yeah, sure. So I think neuroprotection is an area that we've been skittish of because it looked like it has failed in so many different situations, and certainly in the CNS, it's not had a great track record. But I think as in many cases in the CNS, the retina and the eye end up being really the optimal location to work out these initiatives. And again, Dr. Vavas in our department has an interesting program, along with Kip Connor and others, looking at cell death, photoreceptor cell death in particular, in different models of retinal disease, ranging from retinal detachment to models of macular degeneration and also inherited retinal degenerations. And has found that although apoptosis, which is the cell death pathway we know best, is certainly active there, turns out that programmed necrosis or necroptosis plays a major role. And if you inhibit apoptosis only, you end up driving the photoreceptors into another cell death pathway, the necroptosis, and you're not able to prevent cell death. So he's demonstrated in a nice series of experiments that with this combination approach, you can really protect the cells. And it seems to work across all of these models that he's pursued. So we're really keen and would love to get this into clinical trials. We're just trying to move that to the next step.
That sounds enormously promising. What specifically are they inhibiting? Telomerase?
No, it's necrostatins actually that inhibit these RIP kinases that are part of the control mechanisms for programmed necrosis. And they're pretty simple little molecules and easily delivered. It's a little more complicated to obviously target two different pathways. But I think that's something that one could approach, and it could have application to a whole slew of retinal diseases, certainly macular degeneration, but also the inherited retinal degenerations, and even cell death in situations like diabetes and vein occlusion and others. So really broad-based approach.
That is extraordinarily promising news. Perhaps the last question is for patients. You've given us this wonderful panorama of work that's going on. What elements of this work is closest to the clinic?
Well, that's a great question, and I think our patients are always asking, particularly those with early macular degeneration, what about me? You guys have done all this work on what's really the end stage of the disease, and now, we need something earlier. So I think the approach with lipids and the complement pathway is probably what's closest to giving us an answer for patients, and that would be really exciting. I think our patients want to be able to do more than take vitamin supplementation and do a heart-healthy diet, although those things are clearly important as well.
Excellent. Thank you again, Professor.
Thanks very much.
Thank you.